Hello, and welcome to the Borderline Personality Disorder Patient and Family Education Initiative webinar. My name is Dawn Sugarman. I'm a psychologist at McLean Hospital and assistant professor at Harvard Medical School. We are joined today by Dr. Brian Palmer, who is the Vice Chair of Education at the Department of Psychiatry and Psychology at Mayo Clinic and assistant professor of psychiatry at Mayo Clinic College of Medicine. Many of you may have seen Dr. Palmer's previous webinar last month where he discussed medication approaches to borderline personality disorder. We had a lot of interest in that webinar, and participants had a lot of questions about medications. So Dr. Palmer has graciously agreed to come back today to briefly review the material, but spend most of the time focusing on answering your questions. So to go over some of the logistics about that, your microphones have all been muted to protect your confidentiality. You'll see in the bottom right-hand corner of your screen, there's a Q&A box. This is where you will type your questions. You may type questions at any time so that we can put them in queue. Your name, no information will be associated with the questions that you ask. It'll all be done anonymously. Many of you submitted questions in advance, and we'll try to get through as many of those as possible while also answering questions that are submitted during the webinar. If you missed Dr. Palmer's previous webinar, we record them all and post them on our website, and you'll see our website on the screen there. It's mcleanhospital.org/BPD initiative. On the bottom left-hand corner of your screen are some web resources. The first is for our website, and then the next three are resources that may be helpful for you to find a clinician in your area. There's also information about BPD on those websites as well that you can find. And I also want to acknowledge that this initiative is funded by a generous gift from a family that's been affected by BPD. If you're in a position to give a gift, large or small, you'll see a link there to do that as well. And then the last link is to register for our next webinar on October 5th. So without further ado, I'm going to turn the webinar over to Dr. Palmer.
Excellent. Well, good morning, and thank you very much, Dawn. Thanks for inviting me back, and I hope this can be helpful for people. Just as we begin, want to thank McLean. I don't think there's any organization in the country that does as much for borderline personality disorder, for the education of patients and families with the disorder, for advocacy, for research. It's really, it's an honor actually to be invited by McLean to participate in this, and I know that certainly I volunteer my time, but the administrative aspects of running all of these webinars really are expensive and intensive. And since I'm at another institution, I'll just echo Dawn's encouragement to consider making a donation to McLean to support the borderline program there. It's really phenomenal, the work that's being done.
Sorry to interrupt, Dr. Palmer, but could you share your webcam?
Oh, there you go.
Thank you.
Yeah, you didn't want to interrupt the pitch there. There it is. Carry on. So, returning to our conversation from a few weeks ago, I know many of you were there, and some of you weren't, and you're certainly welcome to go back and see the full presentation. I thought I would try to briefly, in 10 to 15 minutes, summarize the high point of that, and then leave the remainder of our time today together for questions and more discussion about medications. So no conflicts of interest that are relevant to this. I do receive some publishing royalties from Harvard Medical School and Oxford University Press. There are no FDA-approved medications for borderline personality disorder, so any specific medication we discuss is by nature off-label, and I will try to present a balanced view based on the medical evidence that is known for the medications that we talk about. So we began last time talking about this model of borderline personality disorder and the interpersonal coherence that helps organize the disorder. And I want to go through it one more time because I think it really helps, ironically, I think it helps inform how we think about medications frequently. So in the top bubble, when a patient feels, a person with borderline feels connected, they tend to settle down. They become more idealizing, dependent, rejection sensitive. Now inevitably there's some interpersonal stress. A perceived criticism, a failure of empathic attunement, something happens, and the patient feels threatened. And the threat is that the understanding that they're receiving is not going to be there, that they're ultimately going to be alone. In that state, they become devaluing, self-injurious, angry, anxious, help-seeking. Now that results in one of two things. On the right side of the slide, the other person may pull away. On the left side of the slide, the other person may lean in more. Oh, God, I'm sorry that I upset you. Or, God, you're upset over that? What's up? And if they get more support, they may then return to feeling more connected. If they get a withdrawal from the other one, then the aloneness that they feared to begin with emerges, and that's where we see the dissociation, the paranoia, the impulsivity, help rejecting. Crisis is ensuing, and that can progress to a state of despair where they conclude that they're unlovable. And there again, someone may walk out into traffic, and if someone stops to care for them, then they want to be alive because it means someone cares. If no one helps, then they'd rather be dead anyway. And I think even the ambivalence of the suicide attempts can help understand this model. So we began by at least contextualizing the symptoms of borderline personality disorder, the sort of sad, depressed states that occur when people feel more connected, the anxious states that occur when people feel more threatened or uncertain, and the paranoia or alone states that occur when people feel like others have pulled away from them. And that is going to inform our discussion of medications today. To be clear, this is not a treatment plan. Your goal as parents and families and loved ones or professionals, if you're listening, is not simply to move the patient back to the top bubble. It's to help the patient understand what's happening in their interpersonal life that is generating some of their symptoms. So treatment in reaction to any of these states can cause problems. I mentioned last time our study of migraine headaches, not our study, a study of migraine headaches. And in that study, patients were put on a migraine headache algorithm. They had a preventive agent and an abortive agent, sort of standard migraine treatment. And the borderline patients compared to the non-borderline patients had more medication overuse headaches, an overall lower treatment response, and they had a lot more unscheduled or acute office visits. Meaning people with borderline often seek out treatment from medical providers in reaction to one of these interpersonal states that I was describing earlier. And that can cause prescribing to get erratic, and it certainly can cause reactive treatment on both the part of the patient and the part of the provider. So the important overarching goal is, if meds are going to be used in borderline, to make sure they're done stably, predictably, consistently over time to assess efficacy. Then we talked about two aspects of mood disorders. First, we talked about depression, and we reviewed that when depression occurs with borderline personality disorder, as it frequently does, there's about an 85% prevalence. Some studies would say 75%, but it's a high prevalence of major depressive disorder and borderline personality disorder. Major depression tends not to improve until borderline improves. And borderline is the most common reason for depression sticking around. So it becomes very difficult to treat depression. And clinicians can do real harm when they emphasize, well, let's try this med, let's try this med, let's try this med, because the data are that they aren't going to work very well until the symptoms of borderline are stable, and treating borderline as the primary disorder when it co-occurs with major depression is essential. Second, we talked about bipolar disorder. Bipolar disorder also co-occurs. About 15% in bipolar patient samples have borderline personality disorder, and in borderline personality disorder samples, about 15% have bipolar disorder. So these things really do occur together sometimes. In this case, though, they really don't interact very much. So when you look at the course and outcome of bipolar disorder compared to borderline personality disorder, you realize that even though there's a high comorbidity, there tends not to be a lot of impact of one disorder on the other, or vice versa, and they're best treated as independent disorders. So for borderline personality disorder, treatment is helping somebody become aware of their inner experiences, regulate their emotions, learn skills to manage behaviors, these sorts of things. For bipolar disorder, treatment is typically medication that can help stabilize mood and then tracking mood episodes over time to ensure that they're reducing. We then move to talk about the medications themselves. The SSRIs, as you can see on the top, have fairly limited data. They just don't work as well as we hoped they would. They help maybe a little bit with depression. They help maybe a little bit with anger and impulsivity. Okay. Data are probably stronger in men than women on that one. Mood stabilizers tend to help a little bit more overall. They help some with mood instability, some with depression, and some with anger and impulsivity. And then the antipsychotics, again, help some with mood instability and some with anxiety and impulsivity, but particularly with the cognitive and perceptual symptoms, the sort of transient paranoia, hearing things or seeing things in moments of distress. Antipsychotics can be helpful in those moments. So again, to review, the SSRIs are probably the safest, which is important. Establishing a medication that's not going to cause significant weight gain, that's not going to be teratogenic if a person becomes pregnant, et cetera, is not a simple task and becomes really important with borderline personality disorder. So the SSRIs, even though they don't work all that well, may work some and may be the safest and may be useful for patients to consider first line if a medication is going to be considered. The atypical antipsychotics, beware that those often do cause weight gain, particularly quetiapine and olanzapine, which are both studied in borderline personality disorder and both have positive data to support their use, but they are both weight gainers, and that's a challenge. They can help with the perceptual symptoms. They may help some with anger. And then the mood stabilizers may help some with reactivity, but some meds in this class can be a particular challenge with pregnancy. They're meds that typically need to be taken every day, can't miss a dose for a medication like lamotrigine, and there can be some drug-drug interactions with some of those medicines. And then finally, benzodiazepines. That's the only class of medicine that's been shown to make patients with borderline worse. The med that was studied was alprazolam, Xanax, and patients that were on Xanax actually got worse in the study compared with patients that were given an antidepressant or patients that were given a mood stabilizer. So it is, I think at this point, safe to say that we really don't recommend benzodiazepines in the ongoing treatment of borderline personality disorder. So at this point, we've talked that the reality is there aren't any medicines that carry a specific FDA indication for the treatment of any personality disorder, including borderline. Borderline patients can be extremely sensitive to side effects. We as physicians and clinicians can have urges to help. These are patients that are certainly struggling, or occasionally we have the urge to not help, but either of those can be relevant. And medications don't treat emptiness, loneliness, or abandonment fears. We really, in the year 2017, don't have a slam dunk medication here, whereas we do have good psychosocial treatments that are biological as well. Our psychosocial treatments change the brain and change the functioning of the brain, and those, I think, are reliably useful for patients when done well. The medications, I think we need to be cautious with, but we also don't want to be hopeless about. The data are that they can help, but they have some problems. And then I included one slide here on lamotrigine because it was one of the questions that people had ahead of time about the mechanism of action of lamotrigine. And I'm not going to go through the whole slide, but basically lamotrigine on the right-hand side of the slide, you'll see that it's a sodium channel blocker that reduces glutamate and aspartate, which again helps with seizures, but can also help with mood stabilization. So given that at least broad overview, I do want to get to your questions. They were just phenomenal questions, and I hope I could do them justice. So let's take the questions in order. Dawn, are you wanting to moderate this and read these questions back and forth, or will you have me do this part and then?
I'll go ahead. I'll read the questions, but I just wanted to thank you for that great overview. That was really helpful, particularly for people who haven't had a chance to watch the previous webinar. So our first question that we received was from someone who said, for the past year, my daughter has been having a severe crisis, which involves trips to the ER for self-harm and or hospitalization, and it happens in the middle of almost every month. The striking monthly pattern suggests to me that there may be a hormonal element. Can you speak to whether it might be possible to use medication to manage these monthly crises? And more generally, what is known about the relationship between BPD and premenstrual dysphoric disorder?
Mm-hmm. It's a great question and a great observation. So premenstrual dysphoric disorder is certainly a real and important disorder. It affects 3 to 8% of women of reproductive age, and it can have profound effects on mood. So if there's a cyclicity to the symptoms that are not related to interpersonal features, it's certainly plausible, particularly if it's around the time of her period, that this is the case. It's also treatable. So treatment of PMDD typically relies on 2 approaches. One is the use of SSRIs, which can help with stabilizing the mood symptoms of PMDD. The other approach is actually the use of oral contraceptives, and we'll use the oral contraceptives in such a way as actually to diminish or eliminate menstrual periods for some months at a time. That's generally considered safe. When we look at our data in the Mayo Clinic Depression Center, we know that the estrogen-containing parts of the oral contraceptives tend to be the more mood-enhancing parts, and the progesterone can be a little depressogenic, so we tend to recommend addressing the particular hormone in that way. But regardless, I think it's something to take up with a primary care physician as part of a treatment team, and certainly may be a very important thing for your daughter to assess.
Thank you.
So
the second question, my child is uncertain of their gender identity and may be inclined to start taking male hormones. Do we know anything about the interactions of medications and hormones, or more generally about how hormone therapy might affect BPD?
Yeah, this is a tough one, and I would need to know a tiny bit more on the case. I do think there's 2 issues here. One, that for people who have long-standing gender dysphoria, they will often tell me a history where, as a child, they had a sense that they really were just in the wrong body, those things. I think it's a no-brainer that we want to support that transition, that as the patient feels more and more comfortably themselves, that they will do better. I think what gets complicated in borderline, to be honest, and this is not the most politically correct topic that I talk about, but it's true, is that there is a lot of diffuse identity internally, and there are some patients where gender, sexual orientation, arousal to lots of things changes fluidly as their borderline symptoms change fluidly, and that we can do some harm potentially if we chase each of those things in sequence and get reactive to them. So part of treatment for gender dysphoria in patients with borderline is trying to help the patient fully get their feet on the ground, get well stabilized in a good borderline treatment, learn to regulate their emotions, really make sure that things are going fine for them. When that's the case, then I think it's the time to assess whether hormonal treatments or any other treatments, changing gender presentation, considering eventual surgery options, all of those things that we do want to consider for people with gender dysphoria, I think we want to make sure we do those at a time when the patient is more stable. And that becomes a challenge, but it also can be a very hopeful thing for patients that if they're committed to this and want to work on it, then establishing that they're going to manage themselves without cutting, without self-injury, without impulsive behaviors in other areas, that they can learn to regulate their emotions, becomes something to work toward because they often are highly motivated to work in those ways. So that's my overall thing, again, childhood onset, gender dysphoria, absolutely, let's make sure we treat that, identify these young people. We can do puberty delaying approaches or transition approaches as adults if needed. For patients with borderline and gender dysphoria that develops as an adult within the setting of borderline personality disorder, make sure things are really stable and be aware that some of those symptoms can be manifestations of the instability of borderline personality disorder. When stable, though, I think it's important to take the person seriously and be able to understand what's going on and consider medication-based treatments. Of the meds, I think you've hinted at going one direction is a little tougher than the other, but your daughter or your child who is considering presenting as male or transitioning to male, the testosterone does tend to be the one compared to estrogen that is a little more mood destabilizing. And I think it's just important to be eyes wide open as people go into that approach. The approach can do several things. This may be more detailed than you want, but sometimes we'll just try to suppress menstrual periods, and that can be quite relieving for some people who are thinking of transitioning or presenting differently, all the way up to increased doses that can cause masculinizing effects. But that really, it depends on the person and depends on their overall treatment. So that's my sort of more in-depth than I intended to be overview.
Thank you. What do the studies say about hemp oil for treating BPD?
I don't know that hemp oil has ever been studied, and I would be cautious of lots of things that haven't been studied. Again, the idea that there's an external fix that we're going to rely on rather than use it in collaboration becomes a bit of a problem, especially on things where there's limited data. So not something I'd recommend typically.
Okay. I want to get to a question that was just submitted. Someone has asked, do you have any recommendations for over-the-counter supplements or any specific diets that would help with BPD symptoms?
Yeah. The omega-3 fatty acids are probably the best studied supplements in borderline personality disorder. It's hard to get high-quality studies of omega-3s because unlike some of our meds, the pharmaceutical industry often doesn't pay for larger studies, and that becomes a challenge. So the data are still a little thin, but I think if a supplement were going to be used, that would likely be the one that would be safest and potentially most effective in borderline personality disorder.
So this question that was submitted, I'm going to read through, and I also want to let you know that somebody else has written in a similar question about anxiety. So you previously discussed the close connection between BPD, MDD, and bipolar disorder. However, although my daughter has been diagnosed with MDD, I believe she actually finds anxiety to be more of the problem. Could you discuss the connection between BPD and anxiety and whether medications can be helpful in dealing with the anxiety in BPD patients? And I know that in your review you had just talked about the benzodiazepines not being effective, so someone had asked, well, how do we treat severe anxiety in someone with BPD?
Yep, great question, and one of the toughest clinical dilemmas that we have. So in terms of anxiety, just take a step back, that it's an awful part of borderline, that patients feel their feelings much more deeply than most other people, and including anxiety. And anxiety occurs when people are moving forward in life. And so when someone's trying to get a new job or start school or take a class, their anxiety often goes through the roof. And it makes them avoid. And so what we know is the borderline gets better, but part of the reason the data are that they get better is through avoidance, where people are not fully engaging in life and they're reacting to their anxiety. So I'm agreeing with you that anxiety is a terrible problem, and it can make people want to pull away from things, et cetera, for understandable reasons. They're miserable and they feel quite anxious. The best approach for anxiety treatment, whether it's in borderline or whether it's a specific phobia or whether it's OCD or a related anxiety disorder, is approaching the anxiety. Now, patients will need more support. I think what family members can do with anxiety is make sure they're supportive. Expect that it's going to be really tough to take that new class. one of the biggest mistakes that parents make is if their kid starts doing a little bit better, say they get a job or they've got a decent relationship or they're moving out of the house or something and you feel like they're making progress, an understandable parent reaction is say, whew, we got it. Like we can breathe now finally. And unfortunately, that's really the wrong thing to do. Getting more supportive as your borderline offspring or borderline loved one tries to move forward in life is really important. And that anxiety will improve over time. We can all think, the first day of work is a lot more anxiety provoking than the first year or the second year or those things. I mean, at some point, things that used to cause us all anxiety do get better. And so I think one is being supportive and providing some education. Now about the meds, Dawn emphasized this, Dr. Sugarman emphasized this, that we don't want to use benzodiazepines to the extent we can possibly avoid it. There's some data to support the use of a mood stabilizer, and there's some data to support the use potentially of an atypical antipsychotic, although the data are less robust. And then the SSRIs are an option as well, which we would normally use to treat anxiety disorder, but don't really have all that great of data in borderline. So choosing a med, to be honest, I think I would consider the case and I'd consider what other symptoms the person has and try to weigh the risks and benefits. But choosing one of those three classes of meds could be helpful, and then track and see whether or not it was helpful. I think it's a tough question. I'm sure your follow-up is going to be, what about gabapentin, clonidine, buspirone, off-label use of any of these other medicines that we can use for anxiety? The data just aren't there in terms of studies, so I can't say that there's good scientific evidence behind them. But again, I think it's not an unreasonable thing to consider if someone is really plagued by anxiety, but they're really wanting to move forward, using a med that will help them. It's just don't do it in a way that reinforces the avoidance. Do it in a way that supports them moving forward and tries to partner with them as they move forward in life and have the anxiety that comes with that. That's the most important thing to get right. And just to acknowledge that the meds may help some, but aren't going to totally solve this problem. But they can help some. I'm not nihilistic about it. I do prescribe these meds. But again, like we talked about, I didn't emphasize it as much this time as I did last time. Beware polypharmacy, adding one more med, adding one more med, adding one more med to treat these symptoms. It's really going to get us into a pickle and isn't going to end up helping very much. And that's the problem I'm trying to preempt when I emphasize all the support approaches, the approaching life, et cetera. I think those things are really key.
Yeah. And as a follow-up, what would you emphasize for someone, so in this case, the person says the anxiety is really just constant. It's not correlated with moving forward or any life-changing events.
Except I bet it is. Anxiety is rarely simply, even for people with severe anxiety disorders, there's usually a process associated with anxiety where if you actually look at it, it often comes with interpersonal stress in borderline, what's going on in the relationships, what's going on in life moving forward, et cetera, and trying to understand that, make it more manageable. And I think one of the techniques psychologically is to try to name, instead of saying anxiety, say fear. What's the fear? What's the fear of what's going to happen? Then what would happen? Then what would happen? And usually by the time you've done two then what's, most people are kind of like, okay, well, I guess if they all laughed at me at work, I guess they'd laugh at me, and I'd either have to decide to keep the job or not keep the job, or I'd joke with them or something, or if an example I give when I'm teaching about anxiety sometimes, that somebody has a fear that they're going to have a panic attack at book club. Well, okay, then what would happen? Well, the patient said to me, I might wet my pants. Well, okay, then what would happen? Well, I guess somebody would get me something clean to wear. By the time you take it all the way through, you get past the worry, and people are able to manage those fears a little bit. Again, that emphasizes the general approach is to try to approach the thing that's making someone anxious. So to restate, support approach, approaching life, et cetera, and support the patient as they're stepping forward in things. Medications can help. I'm not hostile to them. I prescribe them. And I think consider one medicine, see if it helps, especially with the generalized anxiety, and can reduce that some. And I think that the three main classes of medicines I mentioned have some utility, and then some of the off-label use of gabapentin, clonidine, buspirone may be worth considering as well, but most important to do that one at a time as you're helping a patient.
Thank you. So here's someone who says, my son has been on Vyvanse since he was in junior high school, which was long before the BPD symptoms showed up. He's still on it at 25 years old. What is your opinion on using stimulants for BPD?
Yeah, this is a tough one. There aren't good data, but I think one of the things we talked about briefly last time was some of the mechanism of borderline personality disorder neurobiologically. What we know is that people have diminished activity in their frontal lobes, the planning areas of the brain, while they have increased activity in the emotional parts of the brain. And so stimulants should be a reasonably logical treatment for both attention problems in ADHD, but also for some of the symptoms we have in borderline personality disorder with increasing the brain's ability to deal with what's happening emotionally. So I'm not hostile to the idea of stimulants. I think someone who was started in junior high, I assume that there was an ADHD diagnosis made and there was a workup done at that time. A large number of those patients do persist into adulthood, and if he's still having symptoms and is finding the med helpful, it's certainly a reasonable thing to do to make sure that that's treated. I think the difficult part is that people with borderline are more likely than the general population to develop substance use disorders, to impulsively take medicine, to divert medicine, to sell it or steal it or give it away to make more friends or whatever it is that comes with it. And I think those are the challenges of managing stimulants with patients that have borderline. So it's important, I think, to manage that well as a psychiatrist if I'm prescribing that. And I see the patient frequently, provide short-term prescriptions, assess whether they're taking, ask honestly about overtaking or diverting or those kinds of things, because most patients at some point do have these struggles, and to have an honest conversation about what's going on becomes especially important when it comes to stimulants, given their given their widespread misuse, particularly among college age and young people in the country.
And do you, someone has just asked, do you have any data on the association of BPD and ADHD?
Yeah.
How often that occurs?
Boy, I may have to look that one up for you. I'm not sure that it's super well studied in my mind. I'm about to say 15% because I think that's in the ballpark, but I would have to look it up. So I think, again, when it co-occurs, treating it is appropriate, but I wouldn't, if it hasn't been established, I'm not sure it's worth going to go look for it because you end up in a challenge of the stimulant morass that can actually, I've personally had cases where I've, I think, done harm to a patient or two with trying to diagnose ADHD and start treatment when they're in the middle of borderline treatment because it refocuses things on areas where I don't think it's all that helpful. But if this example is a good one where somebody who's on a long-standing stimulant, not unreasonable to make sure that they're getting their med.
Okay. So this person wrote in, my 19-year-old son with BPD has been on 30 milligrams fluoxetine for the last 18 months and is engaged in therapy. Many of his symptoms are significantly improved but not completely gone. His goal is to join the Army, and he wants to show that he is medication-free as soon as possible. So he hasn't been taking his medication consistently. Is this on-again, off-again pattern a concern?
Great question. First, I'm glad your son is doing better. That sounds like things are going reasonably well. And the fact he's motivated to get into the Army, great. I mean, that's a nice marker that he's got some forward direction in his life and is looking to make things better. So given that the meds are adjunctive, as I've emphasized, I think you as a parent can sort of stay neutral on it, supporting his goal, but encourage him to have that conversation with his prescribing clinician to further assess how they're doing that together. So you can be reassured. I will tell you two things. One, that as I said, that meds are not, the SSRIs are unfortunately not hugely helpful. The data is strongest on fluoxetine for men, so good for him. Whoever is treating him probably chose well, and it sounds like it may have been helpful for him along with the rest of his therapy. The idea of fluoxetine is nice too because it has a very long half-life. The half-life is longer than any of the other antidepressants, so it's actually possible to take fluoxetine every 5, 6, 7 days and have it still, you would need to take a higher dose to get a steady blood level, but it's one that you can miss a dose occasionally. I don't think I want to encourage that typically. It's better that if he's going to be on a med, that he takes it consistently and is committed to seeing whether or not it works. I mean, that's the general approach. But in this case, missing a little bit of fluoxetine and it's certainly biologically not the end of the world for him, unlike some of the antidepressants which have terrible withdrawal syndromes. Fluoxetine really doesn't. So it's not that big a deal, and he's wanting to move forward in his life, and he's wanting to get off meds. I think overall that's not going badly, and maybe the only thing that he could do is just try to talk with his prescriber if maybe there's a way to lower the dose, for example, and see if he does just as well on a slightly lower dose. There may be some other ways to do this rather than him just going off on his own, do it in a more collaborative way, but head in the right direction.
We had a related question that was submitted. So this person's son has been 2 years out of an intensive treatment program. He's doing pretty well, but is on some serious meds. He has BPD and post-traumatic stress disorder, and the parent is wondering if this is, the meds is just something he's going to have to deal with for the rest of his life, or if it's reasonable to expect that he'd be able to get off the meds over time.
Yeah, it's a tough question with post-traumatic stress disorder comorbidity. So meds for post-traumatic stress disorder often do include SSRIs. They can help long-term, and quetiapine in particular has some data to support its use in military populations with PTSD. So it's an antipsychotic that we will often use either together or separately and can help. In addition, we'll use prazosin for nightmares in PTSD, and that can help with nightmares in a little more than half of patients can get better with prazosin, so that's a nice option if people are having PTSD symptoms. PTSD, it depends. If their symptoms can be reduced both through medication and exposure-based therapies, many people can have a very nice recovery from PTSD, and that those symptoms can improve, and borderline tends to improve naturally as people move forward in life. So I don't think I would have my mind that he is necessarily on lifelong medications for either of those conditions, but seeing that the medications are effective for either or both of those conditions and measuring the effectiveness becomes the important point. We do use lifelong medications in psychiatry. For bipolar disorder, for example, that is a disorder where people have mood episodes. The more mood episodes they have, the more likely they are to have more of them. Mood stabilizers help prevent future mood episodes and become very important in the maintenance of that disorder. Schizophrenia, we will often use long-term, maybe even lifelong medication-based treatments to help patients regain their functioning, etc. But borderline is not one where we are talking about lifelong medications, nor is PTSD. Those are disorders where we can use meds to help and then measure and monitor the effectiveness of that. Over time, consider reducing medications as people are more stable and progress is being made.
So the next question is, my daughter has made a lot of progress in several years of therapy, but still has a lot of problems with suicidal ideation and frequently ends up being hospitalized. We have noticed that she responds very quickly to antipsychotics during a crisis. For example, May this year, she started feeling very bad, talked to her psychiatrist, was told to increase her dose of risperidol slightly, She immediately felt better, and they avoided a hospitalization that month. But then she stayed at that higher level. So this parent is wondering if the crises can be managed and hospitalization avoided by increasing the antipsychotic and then decreasing it back to baseline when the crisis is over.
Love the question, and I think the question even implies that you get exactly what I was talking about at the beginning. That if someone is in that second oval, they're more activated, they're struggling, etc., and they receive something external that helps them settle down. It could be a med, it could be a supportive phone call from someone, it could be whatever. And your daughter believes that the antipsychotic increase had helped her settle down. Okay, for the record, I'm not sure that the slight increase in risperidone at the moment of her crisis was the solution to it, but her belief that that helped her settle down. I'm suggesting that there's some placebo effect of the risperidone in the crisis, because there probably was, and that's fine. Someone cared, and they wanted to do something to help her, and that had a meaning to her and help stabilize her symptoms. Great, no problem on that at all. So your question, I think, is brilliant, that it's saying, could you use that external support in a more time-limited way around a crisis? Yes. And we will frequently do that. Rather than increase med, have a time-limited use of a med around a crisis, which the patient and the psychiatrist or prescribing clinician can together determine is the right approach for them. I think that's good care and makes a lot of sense and avoids some of the long-term harm and polypharmacy. So certainly they could do that. It makes you get it. It occurs to me as we're going through all these that I'm giving you the advice that I would give a psychiatrist or a resident that I was teaching or something like that. I just want to say out loud that the parent role in this is a little complicated because those of you listening, don't want to put yourselves in the middle of your daughter or son's medication-based treatment. You will end up in the weeds on that, and then you'll be holding one side of the argument, they'll be holding the other. There will be a split between the two of you, and their psychiatrist is in the middle. It's going to be a challenge that way. So while I'm happy to give you all this information and an opinion, I'm not suggesting that you should, this evening, sit down with your daughter and say, what about this? But if you do sit down, do it, in this case, do it at a time where she's stable, and just say you noticed that and wondered about it, but let it be on her and just take a very gentle approach with it. I think some parents start to learn about this stuff, and there are mistakes that are being made by the prescribers, and then the parents want to try to change the treatment, and you can do a lot of harm that way too. So just a word about the process that we're engaging in here too. So if you're going to make an opinion about your child's med known, at least do it in just a very gentle, like, oh God, I noticed that seemed like that Risperdal really helped quickly, and things are better. I wonder if even just using it during the crisis would make some sense. And then let it go. And it's on her and her prescriber to figure out how they want to use it. But I think it's an okay thing to ask about. It's just asking in a way that respects their autonomy and respects their decision-making.
Thank you. I think that's important. And I'll just say that on October 19th, we have a webinar with Maureen Smith, who will go over having these kind of difficult conversations with your loved ones and talk about some of the ways to do that in a sensitive way that helps further communication. Okay. So this person says, in your presentation, you mentioned mood stabilizers, lamotrigine, and topiramate. What about Depakote? How does it compare to the other two as far as being tolerated and side effects?
Yeah. So Depakote or divalproic sodium it certainly is a mood stabilizer. It's a very good mood stabilizer for bipolar disorder. It is unfortunately a med that causes fairly severe and frequent birth defects in women who have an unplanned or unanticipated women who get pregnant on Depakote. So the biggest issue is making sure that there is appropriate birth control. And in my practice, I won't prescribe Depakote to a woman with borderline personality disorder who frequently can be sexually impulsive who are in her reproductive years, and unless she's on a serious form of birth control like an IUD. And if she is, and she's committed to that and wants to consider Depakote, I will consider it. It may cause a little more weight gain than the other two that I mentioned, and it may have more liver effects. It can have other negative side effects like some hair loss occasionally and those things, but if that happens, people can deal with it or stop the med. But it's a reasonable med. There is some data to support its use in borderline personality disorder. It can be stabilizing for patients. And so while I mentioned lamotrigine and topiramate first, it's only because those two have a little bit better safety profile and might be more first line. But if you have an offspring or a loved one with borderline personality disorder who's already on Depakote or who's considering it, as long as the pregnancy issues are addressed and they're aware that it can cause weight gain, liver effects, and a few other things, it's fine and may be very helpful. I've certainly had patients with borderline personality disorder who did quite well on Depakote, and so no hostility to its use. Just beware those other parts.
So we had a question submitted related to mood stabilizers as well, where this parent, it says, my daughter with BPD was prescribed lithium about 6 months ago, and she's gained approximately 60 pounds since then. And her thyroid seems to have been impacted by this, even though her TSH level is not extremely high. Is this something that you see in patients?
Lithium can cause weight gain. I don't know that I've ever in my career seen it cause 60 pounds, so I think I would wonder what else she's on, including something like olanzapine or quetiapine or an antipsychotic that can cause more weight gain. That would just be my question. Lithium for borderline as a primary agent, it has mixed data. It used to be that we would teach don't do it. I think given the fact that it certainly does have some data to support its use in preventing suicide when it's taken regularly, that it can help with churned up internal states, and the fact that bipolar disorder has a high level of comorbidity with borderline personality disorder, I think more clinicians are seriously considering its use. So I wouldn't endorse it or reject it out of hand. It's harder to take. You have to monitor blood levels and that kind of thing. I will say about the thyroid. So let's assume that this person does have bipolar disorder and is treated with lithium for stabilization, which would be entirely reasonable if bipolar disorder is the case. It's the best medicine we have for mood stabilization and bipolar disorder, especially for a young person. The issue then would be to monitor the thyroid, and we actually do treat the thyroid and take that seriously. So it's not that you need to stop the lithium for thyroid effects, it's that you need to supplement with thyroid hormone to make sure that they're being treated well. We have data out of Mayo Clinic in our depression center that fully optimizing the thyroid using levothyroxine in lithium-treated bipolar patients can improve their depression overall, so that we really want to fully optimize thyroid functioning in lithium-treated bipolar patients. It does cause hypothyroidism in 25 to 30% of patients, so it's important to address, but get the thyroid, if they haven't, it's important to get the thyroid checked and potentially supplement if needed if they're going to stay on the lithium. Again, if lithium's causing 60 pounds of weight gain, I do think somebody needs to ask an important question of what are the risks and benefits, and just weigh the risks and benefits of what's going on with that. It'd be a little unusual for lithium to cause that much weight gain, but it can cause some weight gain, and that's worth being aware of. But if thyroid disease occurs with lithium, and it frequently does, we want to monitor that and treat that appropriately, and we can really help the lithium be more effective for particularly the depressed phase of bipolar and maybe for borderline personality disorder.
I just wanted to ask if there's any merit to promoting antidepressant medications, even just for their placebo effect.
Yeah, I mean, I think most, in the year 2017, most physicians are a little cautious about prescribing placebo. I mean, we want to be transparent with patients, and we want to help patients make informed decisions about their medication treatment the way that kind of respect all of us would want to be shown. And so we tend not to use things for placebo effect. At the same time, as I mentioned earlier, we're aware of placebo effect, that if in a crisis somebody has a medicine that comes from a bottle with my name on it and they find me to be a supportive person, the meaning of that is also part of why the med helps. And that's okay. That just is part of, especially in borderline personality disorder, part of how things can be helpful. I don't know that, in this case, an antidepressant, promoting it for the placebo effect, I'm not sure I'd promote that because that's a med you would take longer term. But I do think being able to say, if I'm going to prescribe a med, I do want to do it in a way that I believe it's the right thing to do, that it may be helpful, and I want to communicate to the patient that I think it could be helpful, and then enlist their participation in seeing how it works. But I wouldn't undermine myself. I'm not going to bother prescribing a med and say to the patient, well, don't bother. That it won't be useful then. That actually takes away any placebo effect. I think saying it could be helpful, I've seen cases where it is helpful, let's see together if it's helpful for you, is the right strategy, so that you don't want to undermine the placebo effect, but you also don't want to prescribe simply for a placebo effect. I think the middle is kind of where you want to be on that.
I've had a question that's submitted. I'll read it out. My daughter had numerous admissions starting at age 14 with 3 long-term residential stays and numerous med changes. She's been home 5 months now, which has been the longest stay with no trip to the ER or a residential program.
Wow.
And she does not seem to be spinning, or she does seem to be spinning, and I'm worried that things are getting ready to fall apart again. She has been on Latuda for about a year, but now is having a rare side effect, high prolactin level 99 and breast leaking during her periods, and she's on birth control. So this parent is wondering, what is another drug that's similar to Latuda? She has BPD, MDD, ADHD, and is very impulsive, and she's a 17-year-old.
Yeah, and I'm sure she's had lots of exposure to these meds, but everything you're describing makes perfect sense. Latuda is one that we'll use for mood stabilization. It's FDA approved for bipolar depression, and that may be why it was selected. It is very rare for that to cause elevated prolactin, but I believe you that probably is the cause of it. Make sure that somebody has thought that one through, because occasionally people will have a pituitary tumor that can cause elevated prolactin as well, and just that somebody's made sure that that's not the case in your daughter, just that it may not be the Latuda. It could actually be something else before you write it off to the Latuda. But that is something that can happen. So is there a similar med? So Latuda or lorazepam is an antipsychotic by class, and that group of medicines can be helpful with some of the impulsivity in borderline, the cognitive perceptual symptoms, mildly with some of the anxiety that comes. And so it's a reasonable thing, and I guess I would just have to know what she was on before. I assume the reason they chose lorazepam or Latuda was that it's one that doesn't cause much in the way of weight gain, unlike some of them. And so finding one that's more weight neutral, I don't know if she's been on aripiprazole before, but that's probably the most logical next step, because it doesn't cause the elevation in the prolactin typically, and in fact it can help reduce prolactin a bit when it's prescribed together with Latuda, but transitioning over to aripiprazole or Abilify is something that would be a logical next step, unless you tell me that she's been on that and 6 other drugs, and then I guess I would have to know a little bit more, and I think that's between her and her doctor. Again, I'm answering these questions because I think most parents are just desperate for good, reliable information, but I'm a little cautious by giving too specific a medical advice to people I've never met. I mean, I don't know your daughter, and I'm just emphasizing that I'm talking about how these meds work rather than trying to give medical advice for your particular case.
I think that's a good reminder. We've had a question come in about deep transcranial magnetic stimulation, which has been approved for treatment-resistant major depression in the U.S. and many other disorders in Europe. And so this person's wondering about any data on that for BPD.
Yeah. I struggle to answer this question because I don't want to raise hopes. but I will say that a colleague of mine here at Mayo Clinic, Charlene Sampson, did a study in borderline with repetitive transcranial magnetic stimulation, which is approved for depression. She did it a little bit differently than the way it's often done for depression. Instead of left-sided application of the stimulation, she did right-sided application of the stimulation, and instead of 10 times per second, she did 1 time per second, so 1 hertz right-sided. And she did have very positive data for treatment of borderline personality disorder. Now, that is one small study at one institution. It has not been replicated. I don't think that we're at a point yet. That actually has not been published. That data is not yet out there, but we'll be publishing it soon. I don't think that we're at the point in the field, though, where we would recommend TMS for borderline personality disorder. We just don't have that data. And I think it needs to be studied further whether applying it differently may be more helpful, and that there are some aspects of TMS that I think we're all still learning about. And so while I am personally hopeful that we will find some ways to modify the brain that can affect the actual brain structures involved in borderline personality disorder with TMS, I don't think we're there yet. We're not offering that as a treatment here at Mayo. We're not recommending people go to somebody to ask for that. But I do think it's work in progress as we all try to find better and better biological treatments for borderline personality disorder. So that's my cautiously optimistic answer. But at this point, my biggest fear, as I've said I think all morning long, is that if you provide something external to the person that say, this is the dream cure, then the patient loses the emphasis on making narrative sense of their inner experience, learning skills, how they're going to manage themselves, relying on their structure. All the things we actually do know work get undermined. And so I'm really cautious about even talking about positive data on TMS because it may not be replicated. We could do a lot of harm if we put that out there because we will end up undermining treatments that we do know work and focusing on something else external, which just, fuels the cycle. So, sorry for all the hedging on that. I want to just be very cautious in saying that there's a signal that it may offer some benefit. It's not ready for prime time, and beware any treatment that is proposing to fix something externally in borderline personality disorder.
Okay, so I think we probably have time for one more question. Just going off of what you had just said about TMS, someone had written in about neurofeedback and treating BPD. Is there anything
biofeedback?
Yeah.
Yeah, biofeedback is actually not a crazy idea. So in biofeedback, people become more aware of their body responses to emotional states. And often in borderline personality disorder, people have a lot of trouble identifying what the emotions they're having even are, or that they're having emotions. And biofeedback helps people both become more aware of what's happening in their body at the time they're experiencing emotion and be able to regulate that. So that if they can recognize, wait, my heart is beating really fast right now. Oh, I'm feeling a lot of anxiety. Oh, if I do this breathing slower, that actually lowers my heart rate, and I can watch that happen. So we do biofeedback. It's part of it's not the solution to borderline personality disorder, but it's often, at Mayo, we do it with occupational therapists, but it's often something that could be helpful, certainly not harmful, and may be useful.
Thank you. Well, unfortunately, we are out of time, and I think we were able to get through a lot of questions, and I really appreciate you coming back again to answer all of these questions.
You're very welcome.
Remind everybody that our next webinar, if you look at your screen, is on October 5th, and Dr. Mary Zanarini is going to talk about psychoeducation as an early treatment for borderline personality disorder, and you can see the link on your screen to find out more details and to register. And again, you can visit our website where you can find recordings of all of our webinars that have been done. So thank you very much, Dr. Palmer.
You're very welcome.